speaker today on her topic of breast surgery and what we can do for your patients. And if you can flip to the next slide, Dr. Kish, I'm just going to let everybody know that for the CME credits that are attached to this, you will need to utilize the link. It's shown here, or you can see it in your WebEx invite. And then you need your event ID, the 44434, and your full name and credentials to obtain that credit. So if everybody can place themselves on mute, I'm going to turn it over to Michelle DeSimone for Dr. Kish's introduction.
Thank you, Nicole. Thank you, everyone. I'm pleased to announce our speaker today, Dr. Karen Kish, who's our breast surgeon at Nazareth Hospital, Mercy Fitzgerald. She also provides breast health and surgical services at our new community-based ambulatory center, Nazareth Health Red Lion, located in Northeast Philadelphia. Dr. Kish received her medical degree at Drexel University College of Medicine, followed by her surgical residency at Abington, where she was the academic chief resident. She received her fellowship training at UMDNJ in Robert Wood Johnson. And I also wanted to share a patient testimonial with the group today. She 5-star ratings across the board for Dr. Kish, but the one I wanted to share in particular, and I'll make it short. It's a very lengthy one, but just to give you shine some light on the type of character and provider she is. So here we go. This patient says, Dr. Kish is not only one of the finest, most conscientious and empathetic physicians I have ever met, she is one of the nicest, most caring people I have ever had the pleasure to meet. She's incredibly knowledgeable, forthright, and bright. I cannot recommend Dr. Kish highly enough. So thank you, Dr. Kish, and I will turn it over to you.
Thanks, Michelle. I don't know that I heard that patient testimonial before, and actually that's very, very kind. And for me, especially growing up, I've always been taught that when we appreciate someone, that letting them know is the most important thing we can do. So that actually means quite a lot to me to hear words like that. And as the head of our cancer committee at the Mercy Fitzgerald campus, I like to spread that to our cancer team, because I'm actually just very blessed to be working in Nazareth and Mercy Fitzgerald with such a caring cancer team, and I couldn't take care of our patients without them. So I have a huge respect for all of our elementary, secondary, collegiate educators out there who have been doing this over the last year. I feel a little strange talking to a camera and looking at my PowerPoint slides, but hopefully I'll be able to give a little bit of education over the next 60 minutes. And really what I'd like to do is just what it says here, tell you what can a breast surgeon do for you, and more importantly, what can a breast surgeon do for your patients. So I'm going to kind of break the talk into about 3 different sections. Hopefully I'll be able to get through all 3 of those, and would be very happy to answer questions at the end of this. But the first thing that I'd like to point out is that breast surgeons, we don't just treat breast cancer. We're here to help you and to help your patients. We're here to help in that diagnosis and the management and even surveillance of benign breast disease. So I'm going to take a minute just to talk about the anatomy of the breast. There's different types of tissue that I like to talk about when I'm talking to patients about things that grow in the breast. And not everything that grows in the breast is abnormal. There are some things that grow. They may have been there over the patient's whole lifetime. They may have grown during puberty or during our childbearing years, or even after menopause. There are many different things that can come from the different types of breasts. So in the breast, we have the lobules, which are the milk glands. They change over our lifetime. They change over hormonal control. They change over the lifetime in terms of where we are in childbearing. We have fatty tissue and supportive and connective tissue of the breast. So there are different lesions that can come from the connective tissue of the breast. And we have the milk ducts of the breast. So there are different things that can grow from the milk ducts itself. And the other thing that I'll point out before I jump into this is that I like to make sure that when I'm seeing a male who maybe has a concern, pain, a lump, an infection of the breast, that men have the same breast tissue that women have as well. It's just that women have more estrogen and develop into a larger amount of breast tissue versus men who have a higher balance of testosterone and therefore don't have as large of amount of breast tissue as women. So one of the first things that we see as a very common benign disorder of the breast, particularly in younger women, and a very common cause of a palpable lump in the breast is a fibroadenoma. A fibroadenoma really comes from that connective tissue element of the breast. It's the most common non-cancerous lump we see in younger women. Fibroadenomas themselves don't increase a woman's cancer risk, and they can exist in a spectrum of different lesions that grow from those connective tissue elements. So fibroadenoma is something that you see in this picture here. It's a very oval, we describe it wider than it is tall. It has this grayish salt and pepper appearance to it, nice smooth borders. As fibroadenomas, as they grow, or a larger, what we suspect to be fibroadenoma, could be something that's called a phylloides tumor. Not all phylloides tumors are malignant. It's a little bit of a misnomer and something that I like to make sure patients understand. The word tumor doesn't mean a malignant cancer. And treatment options for fibroadenoma and phylloides tumor differ a little bit. With a fibroadenoma, it's possible that we might see that on imaging. We might examine the breast and say these features seem very common with a fibroadenoma, and a patient may elect to follow that with serial imaging and exam. They may elect to have a core biopsy done, which is something that we can do in the office. Or sometimes, and I also like to tell patients, there's not a wrong indication to remove a fibroadenoma if it's something that's really causing them a lot of worry or anxiety. It's benign and it may not ever grow or cause any other symptoms, but if it's a source of worry for that patient, that is certainly something that we can take out. Two reasons that we do take out a fibroadenoma, though, is if it does grow in size at all, and if there's any change in shape. So I will often see patients with fibroadenomas, and if they don't wish to undergo surgery, at least follow them every 6 months for about 1, sometimes even 2 years, but to check and make sure that that fibroadenoma is stable. A phylloides tumor, however, those we always do recommend that they come out because a very small percentage of a phylloides tumor can have a malignant potential to it. And so we always want to be removing that whole mass so that we can check it completely. Here's a very common one, fibrocystic breasts. And fibrocystic breasts, that kind of goes back to the fact that we have all those different elements in the breast tissue. So it can feel very fibrous, you can feel almost elongated, rope-like, cord-like features of the breast. It can be cysts that develop in the breast, so the patient may feel lumps that come and go. Oftentimes it's very much associated with breast pain and tenderness. They can say that, I just feel this lump in my breast. The size of the breast can change. I definitely have a lot of women who might say that their breasts seem larger at certain times of the month, or they seem like they're growing. And you can see discharge that's associated with normal fibrocystic breast disease. It can happen in women before menopause or after, but we always really, if there's a new concern, if the patient says, my breasts have always felt lumpy, but this is something new, I haven't felt this lump before, or this lump is getting bigger, it's always a good idea to have a person sent to us and evaluate and make sure that appropriate imaging and exam and potentially surveillance or follow-up is done. We often talk about limiting caffeine, making sure we're wearing a supportive bra, using NSAIDs, warm compresses, those sorts of symptomatic relief for that pain that's cyclical associated with the menstrual cycles. If someone has a breast cyst, and we'll talk about that in a second, I have a feel. If somebody has a breast cyst, we can offer treatments or things to help mitigate the symptoms with that cyst. Just a word about breast density before we go on, because I think the fibrocystic leads kind of right into that. One of the common questions I get from patients when I'm seeing them is that they've had this letter come back in the mail after their imaging, and it talks about they have dense breasts. And I like to explain that density is normal. Density doesn't increase someone's breast cancer risk just by having dense breast tissue. The caveat being is that a mammogram, if the tissue is very dense, we just may need to add an extra layer of an adjunct screening test to make sure we're really seeing through all of that dense tissue. There's really 4 categories of breast density. You have all the way that almost entirely fatty tissue, which you can get a very clear look through the breast, all the way up to extremely dense tissue. The heterogeneously dense breast tissue and the extremely dense breast tissue, these are 2 categories where you would maybe think about adding another layer of a screening test, whether that's a whole breast ultrasound, or you can use breast MRI as well. Because small things can hide in that image when you're superimposing all that dense tissue on top of each other. 3D tomosynthesis is a very important addition that we had in technology over time, where you really can look layer by layer through that breast, just like a CAT scan. So at the very least of the patients with that heterogeneously dense tissue, I would say that they really should be having a 3D mammogram. And I believe that all of our machines at Mercy Fitzgerald are equipped for tomosynthesis. If they had extremely dense tissue, particularly if they were higher risk, they had a family history or they'd had a prior biopsy that showed atypia, then I would be more likely to recommend having an MRI as an adjunct for screening as well. So here's where we're talking about those breast cysts, and breast cysts is a very common thing that I see in the office. There's really 3 different categories of breast cysts, and those pictures are lined up from the way I see it, left to right. So a simple cyst is that nice clear sac of fluid. It has round edges, it has a white shadow behind it. There really isn't anything within that cyst, it's clear fluid. And simple cysts, we don't actually need to follow them with surveillance ultrasounds or exams. We don't have to take those out. If a simple cyst is very large, think 4 or 5 centimeters or more, if it's causing the patient pain, then we can aspirate that. We can do that again right in the office. I can do that ultrasound guided in the office. We don't necessarily need to send the fluid for cytology, but if it's bloody or if there's a small mass or something that's residual after we aspirate the fluid, then we would send that for cytology, make sure that it's checked that we have no concern for malignancy. A complicated cyst is in the middle, and that's where we may see some debris floating in that fluid, or we might even see what's called a septation, a little piece of tissue that comes and bridges the cyst from one wall to the other. That's something where we would at the very least follow that with exam and imaging, but we can aspirate and or do a biopsy of a complicated cyst depending on the patient's risk factors and what their wishes are. And then a complex cyst is the one that's all the way opposite. That has a solid component to it. And a cyst that has a solid component is really something we should be biopsying. We do have the potential to do a core biopsy, which means taking a small needle through the skin and just taking a portion of that lesion. But if there's an inconclusive result, or if there's a large solid component, or something is just not concordant, it's not matching up, then those are ones that I would actually counsel to have a surgical excision for a complete pathologic evaluation. Talk a moment about hyperplasia. So hyperplasia is just growth of cells, and not all hyperplasia is abnormal. And we have, like I said, milk ducts, glands in the breast, both of those can grow. So we can have hyperplasia of the lobules, we can have hyperplasia of the milk ducts. And a lot of times you might see on a biopsy that you order, the result comes back saying usual ductal hyperplasia. It just means there's normal growth of the milk duct tissue. Where we get a little more concerned is if we see atypical hyperplasia. So we can have atypical ductal hyperplasia, which means that some of those cells that are growing in the milk duct, they're not a cancer cell, but they don't look entirely normal either. And with atypical ductal hyperplasia, especially that found on those small core needle biopsies, we need to do a surgical excision of that area, because there can be anywhere from a 5 to 15% upgrade rate that there could be DCIS sitting nearby, or even an invasive cancer sitting nearby. On the other hand, atypical lobular hyperplasia, That's not something that we typically need to remove unless there's something that's not matching up. You know, we see a mass and the biopsy comes back atypical lobular hyperplasia. I wouldn't really expect that result to make a lump in the breast. So we may counsel to say, you know, we need to have that surgical excision done. But we do know that with atypical lobular hyperplasia, those patients are at a higher risk than the general population of making a cancer change in their lifetime. So those absolutely are people that I would survey and see in the office once or twice a year for exams and make sure that we are doing mammograms yearly and thinking about adding MRI screening as well. Intraductal papillomas, these are something that you may commonly see coming back on a biopsy report. And the way we treat them has evolved and changed a little bit over the years. So for an intraductal papilloma, they're little small growths within the milk duct. They're described as a warty growth in the milk duct. And typically I would expect it to be something that's maybe 3 or 4 or 5 millimeters. It's the most common cause of a woman presenting with a unilateral bloody nipple discharge. Intraductal papillomas, say someone comes in with a one-sided bloody discharge, we would send for a mammogram and an ultrasound. If that did not show anything, or maybe it just showed some dilated milk ducts behind the nipple, we would recommend MRI to take a look and see if we can find that papilloma. We do generally recommend those core needle biopsies for the papillomas. This is where we had difference. If we had a papilloma on a core biopsy years prior, we would say they all needed to be removed with a surgical excision. But what we now know is that really the ones that have atypical features in that papilloma, yes, we need to remove those. And again, because there could be risk that there could be a cancer or DCIS sitting by. But if there's a papilloma that really matches up between the exam, we're not feeling or seeing anything more suspicious, between the imaging, you know, we see a 3, 4, 5 millimeter intraductal lesion. This makes sense that it's a papilloma. Then we can give the option of surgical excision versus just watching that area, you know, with some surveillance every 6 months for maybe about a year. If there's something that doesn't match up, if I see a 1 centimeter mass in the milk duct and the result is a papilloma, that's somebody that I may counsel to say, you know, that surgical excision might be better so that we can have a complete histological look at what's going on in that milk duct and really make sure that we don't see any atypia or any cancer changes. This is one that we see a lot of as well. So mammary duct ectasia, periductal mastitis. And I put this little cartoon picture here because I thought it actually showed pretty clearly what the pathology is that is involved in these central breast abscesses. The more common presentation of a woman with a breast abscess is somebody that is lactating, they're nursing, a milk duct may get plugged, it may turn into mastitis, it may then form an abscess in the breast. But we can see abscesses that occur in women who are not pregnant or nursing. And the most common cause of those can be that there's something that's plugging that milk duct so that we're not getting drainage through that milk duct. Smoking is a big factor, and I know it's one that a lot of our patients have a hard time kind of matching up that could be a cause or a factor, and it's a difficult thing to stop smoking. I really understand that, but in these women, it's really best, and we do strongly counsel to try to stop smoking. But what happens is that you get hyperplasia of the, or metaplasia of the milk duct, and that milk duct becomes plugged, so an abscess can form right behind it. And then it either gets drained or it actually ruptures and drains on its own. And without you being able to do something to prevent it or not, you can form a fistula. So it's actually very much like forming a fistula in ano with perianal abscesses, is that the abscess ruptures to the other site or we drain it and then a little sinus tract can form. And so that's one reason that these are really recurrent. When that fistula tract gets plugged up, the abscess can recur. Let's say the fistula doesn't form. The other thing that can happen is that the next milk duct over, if we keep smoking or whatever the reason is that we had that duct plug up in the first place, that happens to the next duct over, and then we can have another abscess form. So this can be a really difficult disease. We do treat it symptomatically with antibiotics as needed, draining abscesses. Sometimes we may need to go in and do a surgical excision. This is a picture that actually shows that fistula tract coming from the edge where that abscess ruptured through the milk duct through the nipple. So sometimes we need to go in there and excise that chronic sinus tract and the little chronic cavity to help try to break that cycle of the recurrent abscesses. But I am usually very upfront with patients to let them know that this can be a very recurrent disease, and just draining one abscess doesn't mean that they won't have another problem with this in their lifetime. And then lastly, I think under the benign category, I have here fat necrosis. Fat necrosis is something that is a result of prior surgery on the breast. It could be prior trauma on the breast. It can present both on exam and imaging to look very suspicious for cancer. And oftentimes we do need to have a biopsy done. We will see these changes of fat necrosis, and we may watch that area again with some surveillance short term to make sure nothing else is evolving or coming of that. But fat necrosis is something that we can see after someone has, say a bilateral breast reduction, or they've had a lumpectomy before, or commonly if someone's been in a motor vehicle accident and they've had a large hematoma of the breast, any trauma changes can cause fat necrosis in the breast as well. Nipple discharge, one word about nipple discharge. There's many different causes that we can see for nipple discharge. When we see a patient, I evaluate, we do a complete exam, we make sure that imaging is ordered to rule out an underlying malignancy, and I usually check some laboratory studies to make sure our thyroid's functioning well, there's no evidence of kidney dysfunction. We check prolactin levels to rule out in pituitary adenoma, and infection as well can cause a discharge of the nipple. If everything is ruled out, it can be physiologic and a normal part for the patient that they have this discharge, but we want to make sure that we've checked everything out and ruled malignancy first. So we're going to move on rather quickly to, what does a breast surgeon do for your patients? Well, we can diagnose and manage breast malignancy, and I should have put on here too, including surveillance of breast cancer survivors. So breast cancer is one of the most common cancers. It is the most common cancer in women in the US. 1 in 8 women will have had a diagnosis of breast cancer in their lifetime, but our survival rates over time, we just keep to get, we continue to improve. We have earlier detection, we have good methods to screen the breast, and we have really good individualized treatment options for what we know about the different types of breast cancer. So quickly, to kind of go through these slides, let's talk about some of the landmark studies that really evolved how we approach breast cancer surgery. And these go back into the 1970s. So the NSABP, the National Surgery Adjuvant Breast and Bowel Projects, we had many different studies that is what we still cite today as to how we can treat women the way that we do. So NSABP B04 from the 1970s, we were really trying to see if women could have the same outcomes for local regional control without having to undergo a radical mastectomy. A radical mastectomy would remove the pectoralis major and minor muscles. It would really leave the patient with skin over their rib cage. It would remove a large number of lymph nodes under the arm, and there was a lot of risk of nerve injury and lymphedema. So in the NSABP 4 trial, we know that they found no difference in disease-free survival, their relapse-free survival, distant disease-free survival, or overall survival. So we could do a total mastectomy. We did not have to be doing that radical mastectomy, and only had to remove lymph nodes if there were positive lymph nodes under the arm. So NSABP B6, this was a study that really looked at women. They were stage 1 or 2 disease, and the stage is determined by how big the tumor was. These tumors were less than 4 centimeters, but stage 1 and 2 also deals with, do we have lymph nodes under the arm that are positive or not? And it compared doing a modified radical mastectomy versus a lumpectomy and adding radiation versus a lumpectomy alone. And this is how we know that there is no difference in survival, all of these survivals listed, between women who underwent mastectomy or underwent lumpectomy with radiation added. And this is just very hallmark to how we approach and treat early stage cancers today, that we can have breast conservation therapy. So breast conservation therapy, that is doing a lumpectomy. I explained to patients it's removing the cancer change with a margin of normal tissue around it. Indications for breast conserving therapy, DCIS, the T1, T2 tumors means any tumor less than 5 centimeters. We need to make sure, though, that the patients don't have any contraindications to having radiation treatment, because as that last trial showed us, we need to add the radiation to lumpectomy to have those overall survival rates equal to the women undergoing mastectomy. We need to have acceptable cosmesis. So that's one of the things with breast conserving therapy. We might have a very small tumor and a small petite sized breast, and that's fine. But if we have a larger tumor, say a 3 centimeter tumor and an A cup breast, we may not be able to have an acceptable cosmesis, and that might affect what type of surgery we recommend. Conversely, in someone who has a large sized breast, we might have a 5 or 6 centimeter tumor that we could still remove with breast conserving therapy and have an acceptable size and shape cosmesis of that breast. Contraindications to lumpectomy would be that they've had prior radiation therapy. So once somebody has had if they've had a breast cancer, they had a lumpectomy, and we treated the breast with radiation already, we really cannot treat with radiation again. Those women really would be recommended for mastectomy. If a patient is pregnant and we can't deliver the radiation safely to the patient, patients that have multicentric tumors. So multicentric means that when we break the breast up and we look in 4 quadrants, they have tumors that are in 2 different quadrants. And we need to make sure that when we're giving radiation to the breast, our fields aren't overlapping and creating a very small amount of tissue that's getting too much radiation delivered to it. So multicentric tumors, we would recommend mastectomy. If we can't obtain negative margins, so for an invasive cancer, we have what's called no tumor on ink. It means we just can't have those cancer cells touching the edge. And if we have a positive margin with a lumpectomy, then we go back to surgery. We can try to re-excise those margins twice, or as long as it's going to give us an acceptable cosmesis. So if it's a small size breast and we re-excise once, but re-excising again might lose that cosmesis, then maybe we would only offer 1 re-excision. And that's something that I counsel all patients on that are having breast conservation therapy, is that we don't know what that margin status will be, unfortunately, until we get the pathology result back. So we may need to go back to the operating room if we haven't had a clear margin. If we go and we re-excise twice, the chances are at that point that this disease is more widespread, that we cannot adequately treat the cancer with a lumpectomy alone. And if a patient can't tolerate radiation therapy for any reason. Relative contraindications. So a multicentric tumor means more than 1 quadrant of the breast, but a multifocal tumor is that there's more than 1 tumor in 1 quadrant of the breast. And we do know more and more that depending on how close those tumors are together, we may be able to remove them with a lumpectomy and still deliver adequate radiation therapy to the breast. So that's not a total contraindication. Connective tissue diseases. Sometimes there are other factors that would be a higher risk for that patient to have radiation, and then a large tumor to breast size ratio. And there are ways that we can sometimes give what's called neoadjuvant therapy to help shrink that tumor down to a size where we can perform a lumpectomy. So indications for mastectomy or removing the breast, it would be advanced disease that we would say is a 5 centimeter tumor or greater, again, taking into account the size of the breast. We talked about this multicentric and multifocal disease. Inflammatory breast cancer, that is where we have breast cancer that presents with a red, inflamed looking breast. That surgical treatment is mastectomy. Paget's disease of the breast is cancer of the cells of the skin of the nipple. And for Paget's disease, we can see in 10 to 20% of those women that they may have an underlying breast cancer in the breast, in which case mastectomy would likely be the appropriate treatment. Or if the Paget's disease is only affecting the nipple, they may have what's called a central lumpectomy, which removes the nipple and some of the tissue right behind the nipple as well. We talked about our positive margins, and if we've had prior lumpectomy and radiation, we do need to have a recommendation for mastectomy. Contraindications to mastectomy. So if we know that a patient is stage 4, we know that they have metastatic disease, removing that tumor at the breast itself is not going to change what their overall survival will be. And in fact, it can delay them getting to that systemic therapy that they need, whether that be chemotherapy or immunotherapy. So if someone does have, unfortunately, metastatic disease, that's where our medical oncology colleagues would come in and help to give adjuvant or chemotherapy, immunotherapy. If there's locally advanced disease, so when we diagnose cancer, we do look to see what is the relation of that cancer to the skin, what is that relation to the pectoralis muscle behind the breast tissue. And we always want to have what's called an R0 resection. It means we've removed all evidence of the disease, both grossly and under the microscope. If we have a cancer that's growing into the chest wall, our medical oncology options are so great that we would actually treat them with those systemic options and see if we are able to shrink that or get that tumor away from the chest wall to hopefully get that person to a point where we can have a successful surgery. A quick couple of words about prophylactic mastectomy. We see this a little bit more these days. Prophylactic mastectomy means this patient doesn't have cancer at all, but is removing the breast tissue to help reduce the rate or chance that they can develop a breast cancer. So pretty good reasons to have a prophylactic mastectomy. Patients who have a gene mutation in either the BRCA1 or 2 genes, we know, and we'll talk a little bit later, their risk of developing a breast cancer over their lifetime is very high. Some women might consider this if they have a strong family history of breast and ovarian cancer, even without genetic testing. And sometimes a woman who is a very young cancer patient that has a really aggressive tumor, they may consider removing the opposite breast that is disease-free, just because we would assume that their risk is very high of developing another cancer in their lifetime. So why do we see the rate of mastectomy climbing? We just talked about breast conservation therapy, we talked about lumpectomy, and how we can safely treat many early stage cancers with lumpectomy. So then why are we seeing more and more women ask and undergo mastectomy? Well, we do see that we are seeing younger patients diagnosed with breast cancer. And like we said in the last slide, some younger women, or particularly women with aggressive disease, may elect to have a mastectomy and reconstruction to help eliminate or make their risk as small as possible of another cancer. We have more access to genetic testing, so we have more women who know that they carry a mutation in this gene and have better idea of what their risk is. We have patient education, so you're the front lines, you're seeing patients, you're taking those histories, you understand that a family history that's full of different cancers, they can be referred to genetic counseling and see what their risk really is. And we have an increasing availability of really good reconstructive options for the breast. So it's not that they have the breast removed and they are needing to have a prosthesis or they don't have a breast. We have a lot of very good reconstructive options available. I put this down here with the asterisk, use of MRI. MRI is a tool that has very good use in certain circumstances. Certain types of cancer, lobular cancers, they would really benefit from having an MRI because they can sometimes be difficult to see on a mammogram. People who have those genetic mutations or maybe have had biopsies with atypical ductal hyperplasia, atypical lobular hyperplasia, we use MRI to really screen their breast. There is some positive rate, though, that when we are doing a lot of MRIs, we tend to have small things that we can find, and they're not all malignancy related, but it can sometimes lead a patient to make a choice of a mastectomy because there's something we're recommending to follow, or there's something that they perceive could become a problem in the future. So there is some studies that show that the more we use MRI, the more women we're seeing choosing mastectomy over breast conservation therapy. When we're talking about invasive cancer and we talk about spread of disease, the first place that could go can be those axillary lymph nodes. Another big component of the surgical management of breast cancer is to stage the axilla, to biopsy the lymph nodes to see if we do have disease present in those lymph nodes under the arm. And if we do, that helps to drive our adjuvant therapy choices. But what we're seeing over the last several years is that we're evolving our axillary surgery to be less is more. And there are some indications where we may do less of a staging of the axilla surgically, or maybe even omit that surgical staging altogether. So the two types of surgery that we do for lymph nodes, we have what's called a sentinel lymph node biopsy. And not dating myself, I do remember in my residency training when people started to use this more and more. So the idea is that the sentinel node is that first node that's going to see any fluid or anything that we're filtering coming from the breast. So if there was a cancer cell traveling out of the breast, that sentinel lymph node will be the first one to pick that up. The sentinel node, I described a patient as being that like bottom grape on the stack of grapes that you're holding. It's that first one that it's going to go through. And in surgery, we have ways that we can identify that first lymph node. So the first indication that we can do this is that we have a invasive breast cancer, a cancer that has the possibility or potential to spread, and that when we examine the axilla, we do not feel any abnormal or enlarged lymph nodes. And on imaging, whatever imaging we might have, we do not see any abnormal lymph nodes. And that's what's called a negative axilla, a clinically negative axilla. So if we don't suspect that there's any abnormal lymph nodes, we can do a sentinel lymph node biopsy. And it involves that when they're in the operating room, after they're asleep with anesthesia, I inject a radio tracer, very similar to what you would have for a nuclear medicine stress test, and a blue dye. And those get taken up by the lymphatics and travel to the axillary lymph nodes. You can see in the bottom picture, you actually can see the blue lymph node with the lymphatic leading right into it. Why do we use both of those injections? Well, we know that if we use both tracers, it really increases the success rate of finding that sentinel node. And it's really important to find that sentinel node so that we can prevent having to do an axillary lymph node dissection or remove more lymph nodes from underneath the arm. The other indications that we would use a sentinel lymph node biopsy, if we were doing a mastectomy for DCIS, DCIS does not spread to the lymph nodes, so we don't need to biopsy a lymph node if we're doing a lumpectomy. However, if we're removing the breast, there's always a potential we could find a small focus of invasive disease. And after we've removed the breast, we don't have any breast tissue to inject those substances into anymore. So if we have a mastectomy for DCIS and unfortunately we find an invasive cancer on that pathology, we then have to go back to the operating room and do an axillary lymph node dissection, even if the lymph nodes are all negative, because there's no way for us to do the injections to find that sentinel node. Axillary dissection, this is how we used to stage all axillas, and in fact it was part of that radical mastectomy, and it's also part of a modified radical mastectomy. In the axilla we have different layers of lymph nodes, level 1, 2, and 3. We do take out level 1 and 2 in an axillary dissection. We do not take out level 3 unless we see a grossly abnormal lymph node there, because the deeper we go under the pectoralis muscle, the deeper we go into the axilla, the higher the risk is of injuring the blood vessels going out to the arm, injuring nerves that are going out. In particular, we look for the long thoracic nerve, the thoracodorsal nerve. And so the patients have more risk of muscle pain, injury, dysfunction of the arm, risk of lymphedema. Axillary lymph node dissections we do still use. We use that when we have a clinically positive axilla. It means before surgery we feel abnormal lymph nodes there. We may have a biopsy that's proving that there's lymph node metastasis, or we may have imaging that shows an enlarged lymph node that has lost its normal shape of a lymph node. And those are the people that we use an axillary lymph node dissection for. So I wrote kind of halfway down in this column of information that if we have a positive sentinel lymph node outside this Z11 criteria, and I know we're going to get to this study, but first I'm going to talk about the NSABP study, B32, and this is where this was that landmark study in 1999 to 2004 that told us that we can trust a sentinel lymph node biopsy, that we don't have to worry that the first node we take out might be negative, but there's positive nodes laying behind it. And so this was another landmark study that really proved and changed how we treated women with breast cancer. And like I said, it showed that women with one positive sentinel lymph node did not have positive further lymph nodes upon dissection. So it showed that it went in that order of going through the first lymph node to the others. This trial, which is called Z11 from 1999 to 2004, this was another landmark study because no matter what size of the tumor, if we had a positive sentinel lymph node, we always went on to do an axillary dissection, whether or not we would find any more lymph nodes. So if we had a woman and we examined them and there's no signs that there's lymph node metastasis, but we do the sentinel node biopsy and we found a positive lymph node, then they would all go back to the OR and they would have more of their lymph nodes removed. But what this trial showed us is that if they are clinically node negative in the axilla and we have a small early tumor, even if 3 of those sentinel lymph nodes are positive, we don't need to take out more of the lymph nodes because the goal of lymph node surgery is not to remove every lymph node that has a cancer cell in it. The goal is to guide what is our therapy that comes next. And so if we were doing a lumpectomy for these small tumors and their lymph nodes were clinically negative, we were already planning to give that patient radiation to the breast. And so instead of removing more lymph nodes, we simply can treat that axilla with the radiation that we were planning to give to the breast. So this was a very landmark trial, and this is the reason why you may see some of your patients and they have a positive lymph node, but we're not taking them back to surgery to take out more lymph nodes. And it really helps to decrease the morbidity we see with the axillary dissection and decrease the amount of lymphedema that we see too. And you can see here, so the NCCN guidelines, and in the next couple of slides, you'll see that I have a bunch of these set in here. The National Comprehensive Cancer Network, they have guidelines for every cancer that there are. And this is what tells you that a person can come into our hospital, they can come into one of those larger hospitals in the city, they could go to a hospital in California, Alaska, anywhere they're going to present, and they're going to get the same standard, excellent cancer care because we're following these guidelines that are all peer reviewed. This slide in particular will tell you this is exactly how we approach looking at what we do with the lymph nodes in the axilla. And you can see all of this flow chart is a very busy slide, but all of these are peer-reviewed, proven studies to help us tell us what we need to do for these patients. And then this is another amount of information in the NCCN guidelines that will tell us that the sentinel lymph node biopsy, this SLNB, should be performed and is the preferred method to stage the axilla if the patient's an appropriate candidate for it. I want to highlight again our cancer team that we have both at Nazareth and Mercy Fitz. Again, we can't do this without the patient. The patient is in the center of the slide for a reason because we're all here to serve this patient. And we have every single one of these blocks we have available to us on our cancer team. At Mercy Fitzgerald, we are a nationally accredited breast center, and we go through accreditation site visits every 3 years where they make sure that we're meeting all these standards for each and every one of the people that are on the team and all the services that we provide to that patient. So the multidisciplinary care of the breast cancer patient is central to how we treat our breast cancer patients. We are all involved right from the beginning so that we'll never have a patient that comes to me, I go to surgery, they get sent to the oncologist, they say, why in the world did Dr. Kish do that? We had these other options. That would never happen here because we're all on board right from the beginning to make sure that everyone on that treatment team is seeing the patient, evaluating the patient, and in agreement with the treatment plan that is discussed with the patient and that the patient is also in agreement with that treatment plan. Okay, and we're coming up towards the 12-minute mark to 1 o'clock. And what I want to mention next would be what are other things that the breast surgeon can do for you? Surveillance and management of high-risk patients. So these are patients that don't have a diagnosis of breast cancer, but they may be at a very high risk of developing that. A few words about genetic testing. So we have about 245,000 new cases of breast cancer diagnosed each year, and 40,000 of those patients will die from breast cancer each year. But only about 5 to 10% of all the breast cancers are associated with a genetic link that's passed through the family. 50% of those happen in the BRCA1 and 2 genes. And those are the genes that become most important to us when we talk about a hereditary link. So personal and family history of high-risk characteristics really help us identify which patients might be a mutation carrier and then help to get them to a genetic counselor. So who should we screen? So if we have a breast cancer in any woman who's less than 50 years old, or if we have a triple negative breast cancer in any woman who's less than 60, that means that they do not have receptors for estrogen, progesterone, or HER2 on the outside of their cancer cells. Any woman with breast cancer at any age who has an Ashkenazi Jewish heritage, if someone has 2 or more primary breast cancers, not a recurrence, meaning they have 2 separate cancers, they could be at the same time, they could be at different times, it could be 1 cancer in both breasts, it could be 2 cancers in the same breast. And any first-degree relative who had breast cancer diagnosed before the age of 50. These are all people that we should be thinking about screening or sending for that genetic counseling to screen to see if they could be a mutation carrier. These are some more guidelines. We know that the BRCA1 and 2 genes, they run with other cancers as well. Ovarian cancer, obviously we know about, but pancreatic, melanoma, prostate, and certain thyroid cancers. Those are all triggers to say that there could be a BRCA mutation, family history or personal history of any of those cancers. Any family that has a male that has had breast cancer has a high risk of carrying that mutation. And if we know that a member of the family had a BRCA mutation, then we would refer that patient for screening. So the ASBrS, that's the American Society of Breast Surgeons. In 2019, we had a consensus guideline that we put out for genetic testing, because as breast surgeons, we know that this is out there. We know that genetic counselors are wonderful. They help our patients. We know that genetic testing for some people really helps to make sure that they're screening appropriately, changing lifestyle factors that might be risk factors, or even contemplating if they do want to discuss prophylactic surgery. So this consensus guideline really said that all those things I just said to you are true, but really genetic testing should be made available to any patient that has a personal history of cancer, any patient that had previous testing, but they may benefit from having an updated genetic test sent, and we'll talk about that in a second. And that we really need to make this available to all our patients that don't have cancer and need to be screened or have the desire to be screened. And again, here's that NCCN I keep coming back to. In addition to telling us what are the guidelines for treating cancer, it tells us all of these guidelines about how to screen and who we should be screening for cancer. This is just kind of a clearer vision of what was on that previous slide. So any individual with a personal or family history or 3 or more of any of these cancers really should see a genetic counselor. And what do we do at a genetic counselor? So a genetic counselor, they really are very wonderful in explaining genetics. Talk about DNA, our chromosomes, why is it important? What does a mutation mean? What means if I get 1 from my mom and 1 from my dad? How is a mutation expressed? They also use risk assessment tools, and these are some of the risk assessment tools that I actually use in the office when I'm seeing high-risk patients too, particularly this Tyrer-Cuzick risk calculator. So it's a calculator that takes into account age, it takes into account breast density, it takes into account prior biopsies of atypical cells. We also take a look at hormonal risk factors and family history. And what it does is it can calculate a person's 5-year risk and lifetime risk, 10-year risk and lifetime risk of their likelihood of developing a breast cancer. And why is that important? Because it then helps to have a patient have a solid concrete number. You know, if we say you're at high risk, what does that really mean? But if we say your risk is 5% and the general population is 1% to develop cancer in your lifetime, that's a lot different from saying your lifetime risk is 30% of developing cancer versus a normal average person at 1%. And then patients can really help to make decisions to change some of those lifestyle factors that are important. And in breast cancer, a lot of the risk factors deal with estrogen, whether it's taking exogenous estrogen or whether it could be after menopause, really getting to and attaining a good weight, because our estrogen really comes from our fatty tissues after menopause. It also is important because women with a greater than 20% lifetime risk of developing cancer, their insurance companies do need to pay for MRI screening if they so choose to, so that we can be screening those high-risk patients as effectively as possible. So here's those components of genetic testing, the pre-test counseling like I talked about. It'll talk also about what are the implications of test results. They give the patients information on the different types of tests, how much they will cost, what is the out-of-pocket cost, what does insurance cover, and then they also give post-test counseling to your patients. So they are calling and counseling your patients on what the results mean. The benefits of testing: knowledge. Patients with knowledge, even if they find they have a mutation and they elect that surgery is not something that they want at this point in their lifetime, they have the knowledge to make sure they're having the screening they need. They can be seeing a breast care provider like myself for examinations every year. They can educate their family at what their risk is. And then again, we can talk about what risk reduction strategies we can use. The limitations to genetic testing: a negative test result doesn't mean that they have zero risk of developing cancer. It simply means that of the mutations we know about right now, they do not carry any of those mutations. But there could be genetic links to developing breast cancer that we haven't discovered yet. It also means that not everyone who carries a mutation will develop cancer. So we also have to really manage those patients and make sure that they understand that this is not a death sentence to have a gene mutation. That does not mean that they will have cancer, and that we don't know everything about every gene. So we're going to talk in a second about the different types of genetic tests. The ACS Commission on Cancer, we are an ACS Commission on Cancer accredited hospital at Mercy Fitzgerald Hospital, and part of what we do for that accreditation is that we make sure we're following different standards, but they do mandate that we have cancer risk assessment and genetic counseling services by a certified professional, which we do have that at both Nazareth and Fitzgerald. So we talked about BRCA1 and 2 gene testing. We also have something that's called panel testing or multi-gene panel testing. And you can see from this pie graph, there are a lot of different mutations that we do know play some role in the pathogenesis of breast cancer. BRCA1 and 2 are the most known genes and then the most likely genes to be mutated. Those 2 genes are actionable, which means that we would really recommend prophylactic surgery for those patients. But there are many other genes that can be involved. Panel testing can increase the rate of detection of some of those other mutations. So in a panel test, many genes are analyzed. It's one sample, it's one test. The cost is similar to just BRCA1 and 2 testing. We can identify more mutations. But the limitations of that is that some of these genes, we don't exactly know what it means entirely. And so some of these genes, there may be a mutation, but we would not recommend prophylactic surgery for those patients. We would, however, recommend that we're screening them. They're seeing a breast care provider once a year. They're getting their mammogram once a year. We're considering other tests like MRI. And then some of these other genes, they may have that mutation, but they may not express that mutation. So those are some of the limitations to panel testing. And again, genetic counselors provide this post-test counseling for your patients. We're going to kind of really quickly go through risk reduction surgery. We know that with BRCA1 and 2, we have a very high lifetime risk of both breast cancer and ovarian cancer. We can see that depending on the age that we have, risk reduction surgery, salpingo-oophorectomy, or risk reduction mastectomy, that actually changes the benefit that we get in that reduction of the cancer risk. So that the optimal surgical strategy would really be that at age 40, we would consider the salpingo-oophorectomy. And this one saying at age 25, a risk reduction mastectomy, that would give our biggest benefit in risk reduction. But those ages are pretty young, particularly for that mastectomy. And so we can see down here, the risk reduction salpingo-oophorectomy at age 40, the risk reduction mastectomy at age 40, that gives us a pretty good reduction in our risk, but we still do want to give those patients very good breast screening between the ages of 25 and 39. Our prophylactic surgery rates over the years are increasing, again, because we have the knowledge, the testing, the reconstruction. And what about the screening? So this is where A lot of patients come to you saying, where do I need the mammogram? When do I need to get that mammogram? Again, these NCCN guidelines help us out in that. This talks about how do we find who a high-risk person is if they have an increased risk on one of those models we talked about, over 20%, if they've had history of radiation to their chest, if they have, for the Gale model, an elevated risk, if they've had those atypical cells on their biopsies before, or if there's a strong family history. And all of these are patients that I see commonly in my office to help with their surveillance. This will talk about exactly what we do for them. You can see when they should start having and how often they should have a breast exam, when they should start, not before 21, but when we know that they're at increased risk, referral to counseling. It'll talk about when we start screening mammogram, and if we recommend MRI, and then also has good information that I talk to patients about risk reduction. These are some of the guidelines that we have, and these are some of the patients that I see, patients who have masses, they have nipple discharge, maybe the skin is asymmetric or thickened, they have other skin changes, they may have breast pain, they could have a lump in their axilla. All of these are patients that I commonly see and would be very happy to follow that diagnosis, workup, and surveillance. These are also breast screening considerations. And then lastly, we know that there's many different agencies that give us guidelines on when we should start mammograms and how often. The U.S. Preventative Task Force says that we should have biennial screening for women who are 50 to 74. But the decision to start screening before 50 should be individual. They say to stop screening over age 75 because there's not really conclusive evidence that we should. We should use 3D mammograms and use those adjunct ultrasound or MRI for extremely dense breast tissue. These recommendations is very important to understand are for average risk women. So all these things that we keep talking about, which makes somebody at a higher risk, these guidelines do not pertain to those women. So it's always very important that they have a risk assessment before we decide to delay that start or spread out those screening mammograms. Our current screening guidelines from the American Cancer Society, they say we should start annual mammograms at age 45. It can go to every 2 years at age 55, but they should have the option to continue a yearly mammogram. And starting at age 40, again, should be an option to women. Continue screening as long as that patient has a good 10 years of life expectancy. So I also counsel my patients that we can be having mammograms into our 80s if we find something smaller, particularly a small hormone-sensitive cancer. Sometimes these cancers can be managed with hormonal medication, and we're not even talking about surgery or chemotherapy or radiation. This is the ACS guidelines again, but it talks about women should really know what their breasts normally look and feel like so that if there's any changes, they can contact their doctor or their breast surgeon right away. And the American Society of Breast Surgeons, again, we feel that from age 40 to 44, it should be available, and it really is a patient and physician discussion. We need annual mammograms from 45 to 54. It can be annual or every 2 years after the age of 55, and that it should really go to age 75 or as long as that life expectancy is 10 years. But again, these are all based on average risk women. A higher risk women, we really would advocate starting at age 40 and every year. And to be honest, that's what I recommend to all of my patients. And that is probably slightly over our 1 o'clock mark, but I thank you for your attention, and I hope that I've given you some information, and I hope that I've provided you with the types of patients that I'd love to help you manage. And I've been told we need to look at our disclosures again. If anything today, I have given you some CME just by tuning in or at least having your Teams open.
Thanks, Dr. Kish. That was a great presentation. A lot of great information. Real quick, does anybody have any questions for Dr. Kish? All right, well, I'm going to take silence as you don't. If you do, I'm sure you know how to contact Dr. Kish. and you can talk to her on your own. But thanks for your time this afternoon, and just remember to go in and get your CME credit within 30 days of this presentation. We will also put this presentation on LinkedIn, so in case you want to share with any of your colleagues that may have missed it, please do let them know that it'll be out there. So thanks again, Dr. Kish. Thank you all for joining.
Thank you, guys.
Thanks, Dr. Kish.
Bye.
Bye.